Hi, TopMedTalk friends. It's Desiree Chappell. I have some very exciting news for you. I'm going to hand it over to Monty, but be sure to listen at the end of the podcast, and I will reveal our secret.
TopMedTalk. Monty Mythen here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on TopMedTalk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
All right. Well, hello. I'm Desiree Chappell, and this is TopMedTalk. We are live from the European Anesthesiology Congress, Euro Anesthesia 2019, here in Vienna, Austria. And I am with the editor-in-chief of TopMedTalk, Monty Mythen. How are you, Monty?
I'm well, Desiree.
We were able to catch up with Dan Longrois from Bichat in Paris. Dan, thank you so much for joining us.
Thank you for being here.
Can you tell us a little bit more about yourself, where you're from, and give us some details?
So, I work in Bichat, which is a fairly large academic hospital in Paris, part of Assistance Publique, which is a 38 hospital conglomerate. And I had to take up since January one additional academic and one additional non-academic hospital as interim chair, which is part of our hospital groups, to continue chairmanship while waiting for someone who is will be a full-time head of department. Okay. So it includes from Bichat and the other two hospitals all possible kind of surgical activities with the exception of neurosurgery.
Right.
I also have some pediatrics, obstetrics, cardiac surgery. Bichat is the largest center for lung transplantation in France. Also a large program of cardiac surgery, and so it's quite a diverse surgical and anesthetic activity, and the ICUs, since we are in France, are in our department.
Yeah, excellent. So I had many discussions here about, in TopMedTalk, about hypotension, the consequence of hypotension. And often the discussions are dominated amongst us by hemodynamic management. But always in there is how much anesthesia are you giving, how many pain medicines are you giving, how many other medicines are you giving, and what are the deleterious effects of those? So there's variable patient response, there's hemodynamic management, and there's how much drugs we're giving. Yeah. And we're relatively crude in our evaluation of how we determine. I'm sorry, the people listening at home, we have to be honest about the fact that we have relatively limited ways of titrating our drugs, and often we're looking at hemodynamic responses to say enough, too little. Is that fair comment?
So when you look at the evidence, because yes, we need to look at the evidence, it's been striking ever since the first data on the triple low, yes, 2012, showing that if you are hypotensive, too deeply anesthetized, and you seem oversensitive to anesthetic drugs, you are at a higher risk of mortality. So now, statistically speaking, if the effects of anesthetics would be only deleterious through the hemodynamics, yes, you should not find that the three elements, yes, that sensitivity to anesthetics, too deep anesthesia, and arterial hypotension are independently associated. So the time has come now where we have evidence that we need to monitor the interactions between anesthetics, both hypnotics, and that has been on through the EEG for many, many years. We need to look at the hemodynamics. 10 or 15 years ago, we were saying, well, hemodynamics are not a good parameter to evaluate, yes, depth of anesthesia, which is still true, but they're in the background, and we cannot neglect them. And then the novelty it's been moving, let's say, for the past many, many years in terms of looking at how do we titrate opioids, doses and concentrations. Attempts have been many, and now we have come, based probably on what we have learned from the EEG, to monitors that now are ergonomic, for which we understand what we are measuring, and for which data is accumulating, showing that we, by specifically monitoring the effects of opioids and what we call the nociception, anti-nociception balance during general anesthesia, we can have an additional view on the way anesthesia should be managed. So I think that now we have still the clinical observation, which is mandatory, the anticipation on the level and the occurrence of nociceptive stimuli. We can now reliably estimate the depth of anesthesia and the effects of hypnotics, and we are beginning to accurately and reliably estimate the effects of opioids through the monitors that allow us to measure through the sympathetic-parasympathetic balance the way individual patients would react both to the drugs that we give them and to the nociceptive stimuli that the surgeon supplies.
So traditionally, the way we've done it up until now has been the administration of the narcotic type of drugs, the very strong, the morphine type of drugs, on a best guess basis, if we're honest about it. We picked a dose we think is about right. And if the patient reacts in a way that makes us think they're sensing pain, even though they may not be awake and feeling pain, we give more to make those things. So if the heart rate goes up a little bit or something happens, we give more of the drug. You're now saying we can fine-tune that. Is that right?
There's been a shift which came from the drugs. When I started residency in the early 80s, we're having long-acting drugs, fentanyl. And so we were afraid of giving too much opioid dose or concentration, because then you would pay the price, you as a physician, immediately, because you would have emergence which would be delayed. And then, so at that time, the point was underdosing.
Yes.
And this is why we trained at that time that responsiveness to nociceptive stimuli actually are the proof of insufficient opioid concentrations. And then came faster eliminating drugs. So therefore, the price to pay for overdosing was not translated anymore into delayed emergence. It now became translated into altered intraoperative hemodynamics, arterial hypotension. So now the new monitors allow us to look at both sides of the story. Underdosage, not enough opioids.
Yes.
And credibly excessive doses or concentration of opioids. So now we have a look at both sides of the story, and that is similar to what EEG allowed us to do, because before we had EEG, we said responsiveness, movement, or increased blood pressure to a nociceptive stimulus actually translates underdosed hypnotics.
Yeah.
But the lack of responsiveness either corresponded to just the right dose or corresponded to overdosage. And now I think we are able to look through the new monitors at the entire spectrum of the relationship between dose and effect and detect underdosing, right dosing, and overdosing. And I think this is the major shift, and this is what the new monitors allow us to do.
That's interesting. So I'm work primarily in Kentucky, in the U.S., and of course you're familiar with the opioid crisis and the issues that we're having there. So by utilizing some of the new monitoring technology and these different principles, has there been shown a reduction in opioid use, or is it just different?
Yes, definitely. So there have been several attempts with different types of monitors looking at different parameters that estimate the balance between the sympathetic and parasympathetic nervous system. So that is not based on one type of monitor, on one type of signal. It is universal, which showed us for the past years that the usual way of giving opioids was in many, many cases excessive doses of opioids. In a very few instances, it was insufficient doses of opioids. But what came to our attention is that we were overdosing the patients. So that seems to be a universal result of the monitors or approaches that we have used. So the previous monitors in the past years, it's not a new topic, actually were not very ergonomic. So their application to routine clinical practice was limited by pupillometry is a credible tool, but it is not ergonomic. Okay, and now the issue is, do we have monitors that are ergonomic enough and reliable enough to allow us to detect? And the answer seems to be yes.
Yeah, so some user-friendly things out there that makes it very possible to do these things.
And the format they come in, I presume they're sensors placed around the body and or harnessing existing things that we're measuring and pulling it together.
Well,
so you mentioned the EEG. Is the EEG a component of it?
No, not. So the EEG indirectly, if there's cortical arousal upon application of a nociceptive stimulus, a posteriori tells you that the level of anti-nociception, opioid, was insufficient. But it is insensitive and late. If it is there, you have to take it into account. The issue would be to detect insufficient or too deep anti-nociception before you would have the effects on EEG, because those are not sensitive enough. They are late events.
So where are the sensors coming in from? Which variables are recorded?
Basically, every single monitor takes up a signal that is under the influence of the parasympathetic and sympathetic nervous system at different parts of the body.
Yep.
The pupil, for instance, or pulse rate or heart rate variability. And this is a credible signal coming from the amplitude of the photoplethysmographic wave, which is part of what anesthesiologists measure by looking as SpO2, which is oxygen saturation through photoplethysmographic wave analysis. So I think what is important is that we understand what is heart rate variability in other settings.
Yes.
We understand what is the amplitude of photoplethysmographic wave, and then the mathematics behind that on signals that we already know and which are ergonomically then managed by anesthesiologists, so you don't have to use complex or sophisticated interventions such as opening the eyelids or putting the monitor to measure something, renders credible such monitoring in routine clinical practice outside of the research area.
And these monitors are available, we can see them in the trade exhibition now. They're real, they're here.
Yes, several of them. And I think that the success will come from reliable technology and from the effort that those companies will put into educating the physicians. So we have learned from previous experiences in monitoring depth of anesthesia with EEG, we have 25 years of history into that if you launch a monitor without education, especially if signals are new or algorithms are new, it's not successful or not immediately successful. So I think the newer companies coming now to the market have analyzed the difficulties or the failures of the past and consider that educating the physicians adequately and intelligently is probably the key to adoption of those monitors into routine clinical practice.
What is the body of evidence for?
So it's accumulating fairly fast. And what comes is what you have asked and what I have mentioned is that we probably overdose the patients in opioids. And so the evidence now for the moment saying that if you compare two groups, one where the anesthesiologist has the information provided by the monitor versus a group where the monitor is there but the information is not provided to the anesthesiologist, well, the decision-making process is changed. In general, it results into lower opioid doses or concentrations when you use the monitor, and with the result of improved hemodynamic stability. So it's not yet, and it cannot be for the moment, mortality, okay? But the relationship between arterial hypotension and morbidity and mortality is strong enough so that if a monitor reliably is associated with decreased opioid requirements and improved hemodynamics, it is a credible argument saying that it will probably improve outcome.
Yeah, sure. So many of our listeners actually are from the U.S. Is this technology available in the States right now? Do you know?
Some of them maybe, not all of them yet.
Okay.
I mean, you see that the FDA approval and the European market approval are different things.
Yes.
But everybody would like to be present on the U.S. market, understandably. Now, what you were mentioning about the opioid epidemics, I think is not pure, but a mainly U.S. problem, because we do not see that in Europe, probably because very few patients, although they are given opioids in the peri-op period, do not get them, with exceptions of course, when they get out of the hospital. And I think that it's a complex issue.
It is a very complex issue.
The Perioperative Quality Initiative, POQI.org, has just published a series of papers in Anesthesia Analgesia. Now, it was a gathering with some people from around the world, but it was done in the USA and dominated by the USA because of their recognition.
There was a similar attempt in BGA in Europe,
absolutely.
in beginning of this year. So everybody looks now at this. Yes,
but the discussions, I was lucky enough to be at the discussions in the USA, and it was very much recognised that it is tilted, almost definitely, in the fact that it's a much bigger challenge, and as a result of that, possibly you're ahead of the curve now in the USA in addressing it.
There's
still a long way to go.
Definitely. But it is the forefront of everyone's mind. And so in closing, because we have just a couple minutes left, we probably have several different questions we can go, but in the U.S., we're using a lot more multimodal pain management. And, I can envision that a lot of practitioners and providers will be asking, how does that affect this, and how can we utilize this monitor in those techniques of anesthesia where we're reducing opioids and reducing narcotics but still able to monitor our patients. So where do you see that?
So that is a topic of concern to everybody. What we call opioid-free anesthesia or opioid-sparing anesthesia are properly different. The monitors that are now present actually are relevant for opioid-sparing anesthesia. Because most of the information we have gathered with time is with classical hypnotics and opioids and their interactions. Now, if you go for opioid-free anesthesia and you wipe out opioids and you introduce other anti-nociceptive drugs, ketamine, lidocaine, magnesium, whatever you can imagine, we do not fully understand the complex effects of combinations of the cocktails. We do not have readouts. You can if you use a little bit more sophisticated EEG, you can see the presence of ketamine. You can see the presence on the EEG and eventually in the numerical values. You can see the presence of lidocaine. You can see the presence of dexmedetomidine alone. When you combine them, it becomes very difficult. So it is a concern for everybody. So for the moment, while we discuss about those monitors, we stick to the old concept of hypnotic opioid interactions. Even if the opioid-sparing anesthesia lowers now dramatically the doses and the concentration of opioids. So this is the opioid-free anesthesia is for me uncharted territory for those monitors for the moment. So everybody expects, and I think they're undergoing studies which are specifically looking at opioid-free anesthesia, but it is clearly a pharmacological paradigm that I personally do not master, and I'm not sure that anyone in the literature really masters the complexity of the complexity of those interactions.
Completely agree with you on that one. So, Monty, any other questions?
That's good. There's lots and lots to talk about. I hope we can do this again and again as this develops.
I do too.
It's an unmet need. It's complicated, but therefore it's sticking now, which means it must be the right thing.
If I may allow myself to put a conclusion, I think that this issue of anesthesia statistically linked to outcome is going to be an incentive now to review everything. And it is going to be the trigger for very intense research and also for changes in clinical practice. So I'm convinced that is going to be the case.
I've always personally believed that since my personal research. And therefore, that's the value proposition for our profession. It's that we make a difference, and we make a big difference.
Yeah. On that note, I think that's a very important and great way to close. Dan, thank you so much for sitting down with us and chatting about this. Again, we really hope we can hear more about it and hear more about these technologies and your experiences, and we look forward to it.
And keep up the good work.
Thank you so much.
I appreciate it.
Cheers.
TopMed Talk.
Hi, TopMed Talk friends. I wanted to let you know that we have some very exciting news. EBPOM London 2020 is on. We will be having the meeting. It will be the original dates, June 30th through July 2nd. We're going to mix it up a little bit, so be sure that you visit our website at ebpom.org. That's ebpom.org. You'll get more details. We are going to be offering content, on-demand content, as well as live content. All the most amazing speakers that you ever hear at all of our EBPOM events. So that's super exciting. The best part of this whole situation is EBPOM 2020 will be free up until May 31st. So we have a couple more days, May 31st. After that, it's only 150 pounds, and you will have access to all of our content for that. So be sure to check us out, again, ebpom.org. We're super excited about everything we have to offer this year. All of our same speakers, all of the same quality that you would normally get at a live meeting in person, but you can stay in your jammies. Thanks so much for listening, and hopefully we will see you at Live from London, EBPOM 2020.